I'm going to be talking today about a topic of digital therapeutics, and I'll talk a lot about what that means, but I'm going to talk about the application of digital therapeutics to the treatment of substance use disorders and tell you about what's been studied in this space, what's happening clinically in this space, and what are our opportunities in the future of addiction treatment to leverage digital health. So in addition to my academic affiliation at Dartmouth College that you heard about, I wanted to mention that I have an affiliation with a couple of small businesses that are involved in developing and deploying different digital health tools. And I'll tell you a lot about our NIDA-funded center, which we're deeply appreciative of our NIDA Center grant, supporting the infrastructure of our work at Dartmouth. And our center, is one of the priorities of our center in really scaling best practices, has been to enhance some of our academic industry partnerships. And I did want to acknowledge our funding, particularly from the National Institute on Drug Abuse, our center grant, our Clinical Trials Network node, the Northeast node, as well as several grants listed here, from which I'll share some data as part of this presentation to highlight some of the work that some folks in our group have been doing in this space. So digital health is a term that generally refers to using digital technology, like a smartphone, for example, to both assess health behavior in people's daily lives, but also to provide interventions, to provide what are called digital therapeutics on digital platforms, on, let's say, a smartphone platform that can be accessible anytime and anywhere. So there's a measurement piece, and then there's the intervention delivery piece on digital platforms. And today I'll be talking about both of those areas in the digital health space and also how they intersect. And I'm going to start with digital therapeutics. This is, again, a term that refers to clinical grade software that is effective in preventing, treating, or managing a disease or disorder. So it's a medical grade intervention, and you take the active therapeutic ingredients of this medical grade intervention and you embed that into the functionality and the content of software, and you deliver that entirely on a digital platform. So it goes beyond like a health promotion app or a wellness app, and it's really taking an active therapeutic intervention and delivering it digitally. So this might, for example, include cognitive behavioral therapy. That's just one example of many types of therapeutic approaches that you can deliver entirely via software. So this is not synchronous communication with a clinician like telehealth. This can complement and extend what's done in telehealth, but this doesn't rely on any real-time availability of a clinician for this to be delivered as an intervention. And so you're taking this entire model, you're packaging it into this digital delivery platform. And the exciting part of this is that this can be offered anytime and anywhere. And so what's the value of that? Well, first of all, these types of tools can extend the reach and the impact of clinicians, right? We know that our clinicians can't always be with patients. We don't have sufficient clinician workforce capacity to meet our population level need for addiction treatment and also surely for mental health treatment, particularly in the last couple of years with the unfortunate surge of mental health challenges we've been witnessing. So this can be another tool in the toolbox of clinicians they can offer to their patients that can extend the reach of the clinician workforce and sort of supercharge the clinician workforce and extend impact. So it's kind of like a clinician in your pocket, right? It's sort of available 24/7. And I'll show you a lot of data today that underscores how these types of tools, when they're accessible in this way, can greatly improve patient outcomes. We also know that these types of software-delivered interventions can deliver treatment with fidelity to best practices. So we know there can be a lot of variability in what people get in, let's say, the behavioral therapy world. And we know we can deliver interventions in ways that are wedded to best practices and reflective of state of the science practices and can be personalized to people in this type of delivery platform. And virtually any population you can think of all over the world really either has or is expected to get access to mobile devices. This is true of even some of the most traditionally disadvantaged and underserved communities. We've not only done work all over the US, but in several low and middle income countries. And we've seen that communities may not have clean water or landline infrastructure, but they might have a mobile device within arm's reach at any moment. And so it's just a tremendous opportunity to think about how do you harness the widespread availability of these types of digital devices for personalized healthcare delivery. And again, not everyone in the world yet has 100% access to these, but the rates of access have been growing exponentially and are projected to continue to do so. So it's an opportunity, and the opportunity is to really scale, right? So we can take these effective resources and really push out, enable widespread dissemination of these types of resources. And unfortunately, we know that this is a sort of a more timely and significant issue than ever during our last several years during the global pandemic crisis, and when we've seen a big surge in mental health challenges and in substance use in many parts of the world, and increased demand on our clinician workforce, and not just for remote models of care that include telehealth, but also these types of digital therapeutics. And we've seen, and I've been working in this space for many, many decades now, and we've seen we can have a very striking, robust effect on all kinds of health domains with these types of digital tools. I'll talk today a lot about the impact we see for people struggling with substance use disorders, but we've really seen a robust impact on all kinds of health domains, from preventative health to management of all kinds of chronic health conditions. And we can see a big impact on people's functioning and their health outcomes, as well as health-related costs. So this slide is a big picture overview of the many decades now of research that have looked at the utility of digital therapeutics in the treatment of substance use disorder. So this is sort of a snapshot of that literature. And in general, what we see in this research world is that these digital therapeutics, if they're developed well, if they're developed in a way that really has value and clinical utility and engage your target audience, can really have promising effects. So we see that they can have high utility and acceptability to all kinds of diverse populations. I'll share some data examples of that with you today. We've seen that we can have a big impact and a replicable impact that we see replicated time and time again in study after study on health behavior and on health outcomes. We've seen that digital treatments, digitally delivered treatments, can produce clinical outcomes that are as good as or better than outcomes you see in some models of clinician-delivered treatment. And I want to pause there because I'm not trying to suggest that we are saying that technology is going to replace the jobs of clinicians. We know, for example, in the work we do in the realm of substance use treatment, co-occurring issues with mental health, we know that we do not have sufficient capacity to reach our population level needs. And so it's useful to know that the data show that we can have active therapeutic benefit and therapeutic effects from digital tools that can, again, complement and enhance what we do in our more traditional models of care. We see that we can increase quality, reach, and personalization of care with these tools. There's growing body of literature demonstrating the cost effectiveness of these tools. For example, some sort of applications of these tools in sort of real world clinical use have shown that we can reduce costly emergency department visits and inpatient hospitalizations, for example, among people who have access to these digital therapeutics for helping to manage their substance use disorder. And we know that these tools don't have to be static. I'll talk a lot about this today, but it doesn't have to be taking a 8-session intervention or a 12-session behavior therapy intervention and just directly translating that to what you get on a digital platform. We can flexibly create tools that are responsive to people's changing needs and clinical trajectories over time. For example, their needs may change during the course of recovery. And we can create tools that are responsive to that. We don't have to put a lot of artificial constraints on what these tools can do, but they can be most meaningful to what a patient's needs and preferences are at a given time in their clinical trajectory of a recovery process. So I'm going to start by highlighting one example of a digital treatment for substance use disorders that we had the chance to develop. Probably the first version of it was in the late 90s. I'll tell you a bit about how things have evolved with this, but I highlight this as one example of a broader array of tools in this space because it's a digital intervention that's been studied by a lot of people in a lot of different types of studies, heavily supported by the National Institute on Drug Abuse. And I want to just highlight this as an exemplar of a digital treatment for substance use disorder to illustrate to you the different ways it could be provided to patients and to illustrate to you the different types of clinical effects you can see from those different applications. So briefly, and I'm not going to spend a lot of time on this, I'd be happy to talk about this in more detail if there's interest. But briefly, this is a interactive, self-directed behavior therapy, basically, delivered digitally. And it's based on a very strongly empirically supported behavioral treatment for substance use disorders called the community reinforcement approach to the treatment of substance use disorders. So some of you on the call, I know there's a lot of diversity on the call, including clinicians, and this may be something you all know quite well, but it's one of the sort of gold standard behavioral treatments for substance use disorders. And it's a pretty intensive treatment that helps people better understand and disrupt harmful patterns of drug-taking behavior by understanding and disrupting harmful behavioral patterns as well as cognitions, and to leverage a lot of resources in your life in doing that, including personal and social and vocational and other resources to do that. And sometimes this community reinforcement approach to behavioral therapy has been provided along with motivational incentives or contingency management, where people can get tangible rewards for achievements and successes and achieving milestones in a recovery process. So, being able to achieve some level of reduction or abstinence from substances, to being able to engage in therapy sessions, for example, these can be rewarded with immediate sort of rewards for those types of behaviors in this contingency management paradigm. And that's been shown to be very effective in the treatment of many types of substance use disorders, particularly stimulant use disorders. And that reward system, that motivational incentives intervention, is automated and digitally delivered in this therapeutic intervention. And as I'll tell you in some of the studies that have been done with this, some studies have used the contingency management along with the more skills training, community reinforcement approach, and some have not. And we have seen utility in both components of this multi-component intervention. So again, that was very brief. Glad to talk about it more, but it's just one example of a growing array of effective digital treatments for substance use disorders. So this is a pretty intensive intervention. It includes but goes well beyond, trying to increase people's motivation to engage in change, but also has lots of tools and skills training components to help people achieve that, has lots of tools. When it's 2:00 in the morning on a Saturday night and you feel at risk of relapse, what functionality do you have in your pocket right then and there to help you successfully navigate that moment to help prevent relapse when perhaps you have no one to talk to. So lots of things that can be helpful in the moment that can be provide therapeutic benefit. So I'm going to walk you through a few studies, including this is one of the earliest studies done with this. And I've only chosen a few samples of studies here to illustrate some of the ways in which people have looked at the potential clinical utility of a tool like this, and then to highlight when you implement this tool in different ways, what are the effects? What kind of outcomes do you see? And so this first study was a randomized clinical trial where adults who met criteria for opioid use disorder were entering outpatient treatment for their opioid use disorder. And we all know on this call, we continue to have a real national crisis with opioid use disorder, and we continue to have a striking need for enhancing the scope of services and reducing barriers to resources that could be effective for people struggling with opioid use disorder. So there's still a tremendous need to think about how can we continue to enhance services and reduce barriers to care for this population. So in this study, patients entering this outpatient treatment, everyone received medication. So everyone in this study received buprenorphine medication. We know medication is literally life-saving in the treatment of opioid use disorder. And so that was foundation. Everybody got the pharmacotherapy. And what they got randomized on is what type of behavioral treatment they got in addition to the medication. So if you went into the condition that's reflected in the middle column here, the blue column, those patients were randomized to meet in individual counseling sessions 3 times a week with a clinician who was trained to deliver this community reinforcement approach to behavior therapy. So lots of fidelity checks in place to make sure it was delivered in accordance with best practices, but it was this very effective behavioral treatment delivered entirely by clinicians. If the patients were randomly assigned to the condition reflected in the red column, they had a clinician, they checked in with them every other week, but the therapy, the behavior therapy offered to them was done entirely through the digital version of this community reinforcement approach intervention. And so they would, in this study, this was a web-based intervention, then it hadn't been morphed into a mobile app. And in this particular study, instead of going to see a clinician for, let's say, a 30-minute session, they would go to a computer lab at the clinic and individually interact with this digital therapy. And then patients who went into the condition reflected in the gray column received what was considered standard addiction treatment for patients with opioid use disorder in the US at that time, which was not the community reinforcement behavior therapy approach. Unfortunately, that kind of approach isn't widely used across the nation. And so this was more standard treatment as usual therapy. And so basically, this is just one snapshot of lots of data we have from this study and others that shows that even when you offload the bulk of the therapeutic intervention of this effective behavioral therapy to a digital delivery platform, you get comparable clinical outcomes to an exclusively clinician-delivered version of that therapy. And then both of those types of approaches produced significantly better clinical outcomes than standard treatment. And this particular outcome we're looking at here is objectively measured urine toxicology data. So we were looking at urinalysis results to look at evidence of opioid and cocaine negative urine samples. And again, we saw higher rates of negative samples when you got either the digital or the clinician delivered version of the community reinforcement approach treatment. So that's one example of the effects you can see. Here's a different design. Here's a different setting and a different design. And this is a setting where patients entering outpatient treatment at a methadone treatment setting for opioid use disorder were offered the chance to join this study. We did this in New York City. And in this study, patients either went into treatment as usual, so they're coming into the treatment setting and they get the kind of care offered in that setting. So they receive access to methadone medication on a daily basis. They receive the kind of counseling provided in that setting. Or they go into a different condition where they still receive their medication daily in that setting, but their time with their clinician, if you went into this condition, was cut in half and the other half replaced with access to the digital therapeutics. So let's say you went into this condition reflected in the blue column, you, instead of meeting with a clinician, let's say for a 60-minute session, which might have been the standard model, you met with them for 30 minutes, and then you spent the other 30 minutes interacting with the digital version of this community reinforcement approach intervention. And what we found is that when you cut in half clinician-patient contact time in that setting and replace it with this digitally delivered behavioral treatment, we had significantly greater documented weeks of abstinence from opioids in that sample versus those who received standard treatment in that setting. And so what's happening here? So we know that there's a lot of variability in terms of what happens in counseling sessions in a lot of parts of the world. We know that this digital treatment is taking a best practice and delivering it in an interactive way where there's a lot of measurement about what people's skills are and responsive sort of delivery of training to at a personalized in a personalized way. So this is happening with fidelity and at a personal level. And when you can offer that in that way in this setting, we had it translated to a much better clinical outcomes for that subset of patients. We had the chance in this study to follow these participants. It was about 80 patients per study condition, 160 total, that we get to follow their outcomes for a year, for 12 months. And the differential you see on this slide persisted for 12 months, which was very, very striking. And so happy to share again any of these data with you all. Now, let me tell you a different type of a way you could deliver a digital treatment and show you what kinds of outcomes you see here. So again, these are just snapshots. There are lots of studies that have replicated these patterns, but I'm just kind of giving you a flavor for the robust sort of clinical effects you can get with these types of tools. So this was a study. Again, this happened to be a sample with meeting criteria for an opioid use disorder, entering outpatient treatment. And in this study, we didn't touch the underlying treatment model at all. So people were going into outpatient medication treatment for opioid use disorder. And we looked at what happens if on top of that, you give as a supplement to that access to a mobile version of this digital therapeutic. And so it's just an adjunct to the underlying model of treatment. And so what we see here is that when you add this mobile tool to the offering, the service delivery model and what people are access as a service, we see that we can retain a much greater percent of patients in addiction treatment when the tool is part of the care model versus when it's not, versus when they go into standard outpatient treatment. Here we're looking at the first 3 months of their treatment entry. So, what happens from the time they enter treatment to the first 3 months. This is the differential retention we saw in that 3-month window. And we know that treatment retention is a very strong predictor of future clinical outcomes, and that greater retention has a more positive prognosis. And so this was a really important finding to keep people in treatment more when you offer what seems to be a simple tool on top of an underlying care model. And the same pattern emerged when we looked at people's drug taking behavior. Again, this is urine toxicology data where we saw more documented weeks of opioid negative urines among the sample who got the tool as part of care versus those who did not. So again, happy to share lots of papers. There are many people, the National Drug Abuse Treatment Clinical Trials Network that I think many on this call are connected to in different ways, did a beautiful study, perhaps many of you engaged in it, that looked at this tool and sort of implementation of this in a much more diverse array of populations using substances, and had really striking results as well, not unlike the ones I just shared for populations with opioid use disorders. So I wanted to mention to you that if you don't know this, it's something you probably would want to know because it's evolving rapidly, and I think it's undoubtedly a future of healthcare. And that is now digital therapeutics can be prescribed. So I'll start with sort of where we are with the substance use space, but this is growing rapidly. So the U.S. Food and Drug Administration created a new category of medical devices called prescription digital therapeutics. And what this means is you can go to the FDA with data, let's say from a clinical trial, and seek a label. You seek a label that this software is safe and effective in the prevention, treatment, or management of some health condition. And if you meet all their criteria, then you can get this status of being prescribable software. So it's not unlike if you're trying to get approval on a medication and you have to meet all their criteria to get FDA authorization. Here you can get FDA authorization to get prescribable status. So what that means is that if you get this status, a clinician can literally prescribe your software. You can go to a primary care provider or other provider and get a script for a 12-week or 8-week or 6-week regimen of using software for some health condition. It's a really interesting development. So the first one for this was the 2017 FDA authorization of the prescription digital therapy for treatment of substance use disorders based on the tool I just showed you and based on a pivotal clinical trial from NIDAS, National Clinical Trials Network. And then there was a separate indication for that tool specifically for treatment of opioid use disorder in 2018. But what's been really interesting, and for those of you that follow the space, perhaps you've seen that during the pandemic, during the peak of the pandemic, the FDA somewhat lessened their requirements to get this status, particularly with a goal of increasing access to prescription digital therapeutics for mental health disorders because of what was being observed all over the world, really, but surely in our nation around the mental health crisis that has continued to persist, and to give people more options, give them more availability of resources that they can access in the privacy of their own home. Treatment availability is challenging. There's lots of stigma also preventing many people from going. And so this was a way to accelerate access. And so now there are a whole array of tools available through a prescribable status, including a program for kids with ADHD. And there are lots of data under consideration at the FDA now for even additional tools. So this is growing. I'll speak more about sort of what's evolving in this space, but it's something that, as in the clinician community, that you should be aware of, because I think we will find that it will be increasingly offered in lots of different healthcare settings. And to get that status, again, just briefly, you have to be software-driven, evidence-based, and make a claim. So if you're saying this is generally a wellness promotion app, then you're not under the FDA regulatory oversight. This is specifically for something that says it's a medical-grade treatment or prevention or management tool. So I highlighted here some of the effects you see with digital treatments for substance use disorders, but I also wanted to highlight that we've seen similar effects to what I just showed you with all kinds of digital therapeutics for all kinds of health conditions. And these are just an example of that. So, similar effects with really robust and durable effects with depression, with different types of risk behavior, including behavior that can put people at risk for HIV, with smoking cessation treatments, with binge eating disorder, with different populations diagnosed with different types of severe mental illness, including schizophrenia, bipolar, including with kids, with adults, with medical regimen adherence promotion to help increase compliance with medication taking, let's say, or other medical regimens among different populations with chronic health conditions. And that's just a snapshot of what we've seen in this space. And so I think it really underscores the generalizable utility of these types of tools. I'm not trying to suggest that digital health tools are the solution to all of our many healthcare challenges, but it's just striking, the effects you can get and the opportunity to, again, harness the availability of digital access to creatively offer, these hopefully engaging and impactful tools. And so I think, having worked in this space for a long time now, I think that we're at a really interesting moment in time to take, there's a lot of great science. There's a lot of excitement now in the clinical space for this. There's still not really widespread standardized models of access for this, but I feel like we're at a very interesting moment in time that might be a really important opportunity and transition point to scale access to the most effective tools. So first, we know that there's undoubtedly been a surge in demand for remote models of care. Again, not just telehealth. We also, unfortunately, know that we've had a really alarming increase in behavioral health needs at a population level in recent years, and a strong need to give resources that are readily accessible to people and that can be effective. We also have seen truly exponential growth in the digital health industry, again, accelerated during the pandemic, but it was definitely happening before that, where, not only did we see lots of digital health startups and digital therapeutic startups, but we've seen big global pharmaceutical companies building digital health formularies to complement the work they're doing in sort of medications, to build digital health formularies that they would support. We've also seen, particularly 2021 was a peak year, I would say, of this surge in funding of this industry, including in the venture capital world. We're also at the same time seeing multiple paths to deployment. So I mentioned to you the FDA regulatory pathway. And a lot of people were excited about that because, for years, for example, people come to our center and say, I'm excited about these digital tools. I want to offer them to my patients. I want to offer tools for insomnia, depression, alcohol use disorder to my patients. But if I go to the App Store, there's so many things available. How do I navigate that? How do I know what works? What doesn't work? What are best practices? And one of the benefits of the FDA pathway is that if you go through that vetting and approval process, then clinicians can have confidence that those tools that get that authorization have met all those criteria of safety and effectiveness, and it can help them think about tools that they might want to suggest to patients. So that's a real benefit, but that's not the only pathway to deployment in this country. We've seen that big pharmacy benefit managers create their own digital health formularies and their own offering of digital tools that they're going to offer to their network that's covered in their beneficiaries. We've seen employers similarly do that in this country. We've seen other countries like the UK, for example, Germany also have national coverage of digital therapeutics that will be paid for at a national level. So we have a lot of happening across the globe in this space. So it's a very interesting time there. And then also finally, we have an evolving payment landscape. This has been the big issue. It's great. These work. There's strong evidence, exciting, we have different ways to access them, but how are we going to pay for them? And so some of the first movers in this space were private insurance companies. They were employers offering these tools to their employees. But in terms of national coverage frameworks like Medicare and Medicaid, Medicare does not yet cover these, and Medicaid, only several states at a state by state level have been making decisions to do so. And a lot of people have been working really hard on that, but and there's a lot of promise in that space, particularly in the last year, including with some pending legislation that didn't make it through last calendar year, but is being reinvigorated to seek to try to get Medicare coverage. So all of this is so it's a confluence of factors that I feel is really positioning us to sort of take this science, take these tools, and really come up with sustainable and scalable models of making them available to people in their daily lives to really impact people's daily lives. And so I'm going to show you an example of a project we were able to do that illustrates the potential of scaling up these tools, right? Scaling them up from a clinical trial, scaling them up from application in one healthcare setting to thinking about a sort of a way to have digital care offering as part of how you think about healthcare delivery. And I'm going to tell you about a study and demonstration project, and really even a capacity building project that we were able to do in Latin America, funded by the National Institute of Mental Health. And it was focused on scaling up science-based behavioral health care using digital health to do that. So Colombia is an example. We work primarily in Colombia with partners in Chile and Peru, and I'll talk about Colombia first. Colombia is a country, it's an example of a country that has very high mental health burden, but limited capacity for mental health care. We know that Colombia had generations of armed conflict. There has been for years now, 6-ish years of FARC peace agreement. But if you talk to people all over the country, all the communities have been touched by this armed conflict, and there are very high levels of trauma. There are very high levels of depression, high levels of alcohol use, often coupled with domestic violence. And Yet the mental health workforce is extremely limited. And so mental health professionals not only are low volume, but they often are clustered in urban settings like Bogota, for example. So if you go to an urban or a rural farming community, there's often literally no mental health specialist at all accessible to patients. And really their model of mental health care was heavily limited to inpatient psychiatric hospitals. So it's an example of a part of the world where we have high need and limited capacity to meet that need. So how do you solve that problem? So what we trialed here was an approach to leverage digital health tools to tackle that need, to expand access to science-based behavioral healthcare across the whole country. And so to take empirically supported digital health tools and to use that as the basis for the care model that could then be offered across the population. And I'll tell you how we did that. So it was an integrated model of behavioral health care where it included digital screening, right? So we know there are effective standardized assessments to screen people for things like depression, or screen people for unhealthy levels of alcohol use. And then we automated all of that. And in primary care, so this is the first time primary care in that country routinely assessed for anything mental health related. It was not done at all in that country until this demonstration project, interestingly. So it was the first time they was doing these screenings at all in primary care, but we wanted to leverage primary care because that was more widely accessible across the nation. So there was some, of course, clinician training in behavioral health. What is it? Why is it important to you? How does it impact people's overall health and functioning? But we really tried to give them the resources to more readily adopt assessment and care. So the digital screening was on the front end. And then for patients who screened positive, that would then trigger a dialogue with the clinician that included a clinical decision support tool for the clinician. So for the patient in front of you right now, here are their screening data, and it guides you through a process to do a full assessment and to make recommendations about best practices based on their profile of needs. So it's taking these best practices and guiding the clinician through that. And then every patient on top of that care model in primary care received access to a digital therapeutic. In this study, it was for specifically people who met criteria for depression and unhealthy levels of alcohol use. And so that is a way to take these effective behavioral treatments for these conditions and to provide it to patients in their daily lives. And so that was the integrated suite of tools that we offered across the country. And so here's some screenshots of that. So this is just digital screening, for example, that the patient would first see. This is an example of some of the screenshot from the clinical decision support tool that the clinician would see. And then here's some screenshots of the digital therapeutic that the patient would see. We've been able to have sort of NIH support on developing and testing digital therapeutics for a long time. And so this is really a reflection of how do you take best practices in sort of functionality and content and tools in these digital delivery interventions and deliver it in a way that can be transdiagnostic. So if somebody had more than one co-occurring condition, mental health condition, we could flexibly embrace that combination within what they receive through the offering of the digital therapeutic. So these are just some screenshots of that. And so here's just a 2-year period. I'm just showing you data from a 2-year period where we went from screening no one in primary care for these problems to screening about over 22,000 patients. 22% of those patients had positive screens, and then 8% had a diagnosis of depression and or unhealthy alcohol use. So went from screening and treating no one for these conditions in primary care to these kinds of rates. And I'll just show you some data. We did track patient outcomes for a year. This is PHQ data for the patients who had a diagnosis of depression. We saw pretty early benefit from the therapeutic model that got sustained over the year. This was true even for people who started with severe levels of depression at baseline compared to those with moderate or mild, we saw that all of those different subgroups of people with depression had therapeutic benefit from this model. Similar patterns with changes in problematic levels of alcohol use over the course of a year, including, again, people with pretty high levels of alcohol use as measured by the audit when they joined this clinical model, and then saw even those with those high levels of severity were able to have therapeutic benefit from this therapeutic model. We heavily focused on implementation outcomes, what happens at the clinical site when people are asked to take on something new in their clinical workflow. And we looked at all kinds of data around this, and I just will highlight a few examples, but happy to share any more information for folks who are interested. Measures of, the perceived adoptability of this, is it accessible, is it appropriate for the setting, is it feasible is for the setting, is it appropriate for the scope of care in the setting. And what we found on this is that people generally got excited and supportive of this even early on when we first launched the model and sort of introduced the model, and found pretty high levels of sustainment of those perceptions, the level of appropriateness, for example, or perceived feasibility throughout the 2-year period that we collected these data from both administrators and providers, administrators in orange and providers in blue. And so, kind of positive sort of perception of this from the beginning and then throughout the course of the project. We also did pretty granular costing analysis. So this is a metric that came out of Harvard. It's a cost-based utility sort of mapping, process mapping activity. It's called time-driven activity-based costing metric. And it's a very, very detailed methodology where you can track the cost of people's time and process when you embrace some new innovation in a clinical workflow and understand the cost implications of that process versus the process that existed before you introduced this innovation. It's a very interesting method, and I'm happy to talk about it more, but I just wanted to show you that overall, when we looked at the bottom line of what we learned from this process mapping activity across the nation when we did this implementation effort, is that after we launched this model versus before, the increased cost was only equivalent to $1.89 US dollars. And there was a lot of excitement about this in the region because of the potential cost effectiveness of this, right? Because we did see pretty big early and sustained benefit from this clinically. And we know that, helping people manage mental health conditions has all kinds of other implications for their health and health costs. And so the country of Colombia is seeking to expand and sustain this model of care. So again, this is just an example of one setting, one project that highlights how you can take digital innovations and expand capacity for resource delivery. But we could apply this to all kinds of other health conditions, other mental health conditions, chronic disease management, prevention, promoting interventions. And this could be relevant to rural America. It could be relevant to, other settings with high need and low resource. We've been delighted to have an amazing group of partners work on this from all over Latin America, as well as our Dartmouth group that led this, but and won a National Academy Award. That was great. But the most exciting thing is now it's being scaled across the region with the Ministry of Health and with some of the local payers in the region. So what I'm going to do at this point, and I am mindful of time because I want to make sure we definitely leave enough time for questions. I see there are lots of things popping up in the chat that I can't quite view yet, but I will make sure that we get to that. But I'm going to take the next bit of time to transition a little bit to talk about the other part of digital health, which is more about digital assessment, and to talk about how using digital technologies can help us better understand people to provide more effective resource delivery. So not only can these digital platforms give these therapeutic interventions that I've been talking about, but also we can learn a lot about people through these digital platforms, about their behavior, about their health, their environment. And we can learn about that with great granularity as people live their daily lives. And not only can that provide and is providing new insights into understanding individual differences in people's clinical experiences, but also providing personalized interventions and resources based on that type of data. So lots and lots of people working in the space where they're trying to take this granular information you can capture from a smartphone or smartwatch, for example. There's even smart jewelry like wearable earrings and such that have sensing capacity. And you can extract features, and I'll talk in detail about some examples of this, about individuals, and you can build these predictive models to understand, people's changing needs and trajectories over time. When is someone at risk of relapsing to drug use? When is someone at risk of a manic episode? When is someone at risk of a psychotic episode? And understanding when we could best for that person, given the confluence of factors that predict that, provide more personalized momentary interventions. So this digital health measurement space is really looking at, are there digital biomarkers that can be meaningful in understanding behavior in new ways that can complement and extend other sources of data we have, it captured in the moment and within individual, and really understanding behavior and context, right? We have wonderful clinical measures that we can use, structured, validated clinical assessments we can use in clinical trials, in clinical care settings that have great value. This is potentially a data source that can extend our learning, right? So capturing data in people's daily lives, not just in this episodic, structured way. So digital phenotyping is one term that is used in this space, and that's a term that often refers to the moment-by-moment information you can get on digital devices about people's behavior and functioning. And that can be captured in different ways. You can ask people to answer brief questions. Let's say you prompt them to answer very brief questions on their phone. Through ecological momentary assessment on the phone, or through passive sensing. There's an extraordinary sensing capacity on smartphones and on wearables that give you all kinds of information about people, about their sleep, about their activity levels, about their light exposure, about their sociability, and on, that can provide information about people's functioning in a totally passive, unobtrusive data collection way. And the promise here is that, and this is still an ongoing study, which of these data are meaningful clinically to understand people and people over time. So in the field of substance use disorder, I'll talk about that first. We have definitely seen that digital biomarkers are showing promise. And so let me give you some examples of that. There's a bigger literature and a growing literature in the space, but here's some examples. So in this first study that's highlighted, this was a population of smokers who were trying to quit. And what we found is that when we were assessing their mood in a pretty granular way, through EMA, which is this where, the ecological momentary assessment, where you capture sort of self-reports periodically on the phone, we found that lapses to smoking events among the sample were associated with increases in negative mood for days and not just hours before a lapse event. And so, the idea is maybe we're learning some information about predictors and sort of, and the temporal considerations about predictors that might predict, for example, a lapse event. We also saw Kenzie Preston has done some great work in this space, and her group at the NIDA Intramural Research Center. And one of their studies showed that craving captured in a daily way predicted imminent drug use, but self-reported stress was actually much less predictive than craving. And so the opportunity here is to think about understanding differential predictors and the relative predictive utility of different predictors. We also saw from work in that same group that drug triggers, so things like being exposed to a drug cue or a change in mood that might be a trigger for someone, it increased for hours before cocaine use events among one of her samples, but not before heroin use events. So the idea is maybe there's some interesting insights we can find about differential triggers or predictors of use events that might differ across classes of substances. We've also seen that there's promise in capturing this digital data to inform momentary interventions. So one such study has shown that when you measure people's smoking risk based on a certain algorithm in real time, when someone shows they might be at risk for smoking, then when you give them a tailored message in response to that, and like advise them, chew a piece of nicotine gum, at this moment, or some sort of tailored advice, we see that that's more engaging and more effective than usual care. We also see that adaptively tailored interventions for managing withdrawal symptoms. So if you're monitoring, let's say, withdrawal symptoms in real time, you're monitoring medication side effects in real time. When you give people tailored interventions in response to those events, you find that those are more acceptable among smokers seeking to quit than usual care. And our group has been, with NIH support, we developed a metric and validated a measure of momentary self-regulation, where you can capture in the moment people's self-regulatory capacity that's transdiagnostic, that can apply to any population, where you measure in the moment people's emotion regulation, in the moment their perseverance, for example. And we've seen that digital interventions can impact momentary self-regulation across different populations, including heavy smokers, including populations with binge eating disorders, 2 examples. So one study we've just completed and are generating some papers from now that we're really excited about within the NIDA Clinical Trials Network was a digital phenotyping of patients in outpatient treatment for opioid use disorder. So again, we know that we have a significant opioid use disorder epidemic. We know that it is treatable. There are effective treatments. There are life-saving treatments. But we also know that people in treatment sometimes relapse, sometimes drop out of treatment, sometimes don't take their medication. And we have some clinical insights into what might predict that. But this study was an exploratory study to understand, could we better understand in a granular way what today might predict that today that person is not going to take their buprenorphine medication, or today might predict that they're going to use fentanyl. So are there data we can get in people's daily lives that might be meaningful and predictive and offer greater insights beyond our traditional clinical assessments to make these predictions? So what we did here is we asked patients in outpatient treatment for opioid use disorder to, if they join the study, to both provide passive mobile sensing data through a smartwatch and a phone, to answer some questions we prompt them to answer daily on a mobile device, and if they were willing, to let us take their social media data, whatever social media platform they have. And it was an exploratory study to see which of these data sources, if any, might provide utility in predicting things like when people aren't going to take medications, or when they're going to relapse to opioid use. And where's the redundancy, right? Where's there added unique value of the different data sources? Where's there redundancy to really think about, is there some promising set of data from this digital data capture that might help us in future clinical trials? So let's say, we are testing a novel medication and we do all of our traditional structured assessments. Is there some additional digital data we want to capture in people's daily lives on top of that, that might provide us greater insights into people's experience with that novel medication or challenges with it? So that was the mission of it. So we partnered on this with Kaiser Permanente, Cynthia Campbell and her group. We recruited patients at Kaiser in California in outpatient opioid use disorder treatment for the study. So for the sensing data, all kinds of information you can get from smartphones, smartwatches. Here are some of the features that you can collect from these different devices. So we could get all kinds of information about people's sleep and light exposure and proximity to others, and activity levels and heart rate, et cetera. With our queries, we prompted them to answer on the phone. We asked very brief periodic questions about these topics: their sleep, their stress, their pain severity, interference, and catastrophizing, craving, withdrawal, substance use, risk exposure, context, mood, the momentary self-regulation scale I mentioned to you, and also if they took their medications. These were all a sample receiving sublingual buprenorphine medication. And then for social media, if they approved us to look at their social media data and provided it, we took anything they offer from Twitter, Facebook, or Instagram, and we could look at postings, comments, sentiment of these things, social topology and networks, and on with these types of social media data. So this was mostly a feasibility study. First of all, we found that Participants, we were very encouraged by these data. Participants carried the phone on 94% of days, and they wore their watch for 74% of study days. The mean response rate to our EMA queries that we asked them to complete was 70% completion, which was great to see. And 88% agreed to share their social media data. We did not expect that high. Some people had challenges actually sharing it, particularly with Facebook, because of the way we had to do it with Facebook. But 88% said, yes, you can look at these data. And we're still looking at the predictive models. We have some time series analyses that I've got summarized here. We have all kinds of exciting things happening with our analytics in this space now. But for the EMA data that we obtained, we found extraordinarily high predictive utility of next day opioid use. But what really drove that is when people in EMA reported opioid use, that self-report of opioid use was a very strong, and not surprisingly, a very strong predictor of next day opioid use. The predictive utility of this went down somewhat, of course, when we took out that variable, but there's still a lot of encouraging results emerging there. With the sensing data, our team's been looking at lots of the features, but one example is that when you look at the heart rate data and the smartphone conversation data, not what people say, but a measure of interaction with other people, we find that these are generally quite useful in forecasting next day opioid use events from data from the previous week. We also have been looking at predicting future stress, future craving, pain, anxiety with these data, and we're getting similar time series results with that. And the social media data too, with some of the deep learning models that our folks are doing, have been also with some decent specificity and sensitivity been predicting next day opioid use. So these are preliminary data, but they're promising, and we are working hard on finalizing this. And I highlight this though, just again, as an example of, trying to understand the value of this. We're going to look at, as I mentioned earlier, when we look at all of these data sources together, what is the collective utility? Where is the redundancy? So again, this might inform which subset of these types of digital data might be most useful to employ as part of outcome measurement in clinical trials. That's one goal. And also, as this line of research evolves, we might find that we might understand when individuals might be most receptive to a real-time intervention delivery. Like what's the right intervention at the right time based on what that person's needs and might be at that moment. And the predictive models, I think, are not yet there. I don't think we have that kind of precision, and people are very intolerant of false positives. So if you were to say your predictive models suggest somebody might be at risk of relapse and you trigger an intervention and there was some other reason that wasn't a real risk event, people don't tolerate that too many times before they sort of discontinue using your app. So the precision, there's room for improvement in the precision, but people are working hard on it. It's getting better all the time. So just to wrap up this section in this digital health measurement space, if you look at the literature out there, and I mentioned some examples in the substance use space, but the bulk of the work so far that's been done has been in applying digital health assessment to mental health. And that literature, by the way, is very promising and has, for example, highlighted how we can understand people's different levels of severity of depression or severity of anxiety with digital data, or when someone might be at risk of escalation in depression symptoms or other mental health symptoms with these types of data. So and including folks with diagnosed with schizophrenia. So there's a lot evolving in that space that's very promising. As I see this space, it really spans from discovery science to translational science, because you can think about the promise on the discovery science side by, maybe we're going to identify some digital biomarkers that might provide new insights into certain health conditions, but it might also on the translational side help us with outcome measurement, right? We might, as I mentioned earlier, better understand if these types of data might help us measure outcomes over time and changes in people's clinical status. But the literature is still early stage, I would say. That I think it's heavily proof of concept right now. And we don't have, for example, a lot of standardization in what features people extract from, let's say, smartwatch, sensing data, or are these measures validated? We don't have a lot of trials that of these types of we don't have a lot of studies that have control groups or rigorous designs. We don't yet have much reproducibility in the field, although there's lots of promising sort of nuggets that have popped up all throughout the literature. There is a need for a much stronger science here. So if anyone's interested in this, there's a lot of opportunity in this space. And it's exciting. And I think what's exciting is that these digital health approaches can really transcend, disease-specific models of behavior and help us understand complexity and interrelatedness of clinical disorders in new ways. And indeed, we are seeing that, again, particularly in the mental health space. So I'm going to just take a little bit of time. I'm trying to leave a lot of time for discussion because I see a growing number of comments in the chat. I wanted to tell you about our center just very briefly because we are a NIDA supported center and we are a national resource and we want to be a national resource. And so for anyone who is interested in this space, we have all kinds of resources that may be of interest to you, including our networks and all kinds of other resources and learning opportunities that we can offer. And our group is called the Center for Technology and Behavioral Health. And our mission is really to use science. So in this rapidly evolving space I've been talking about, digital health, our focus is on science, right? How do we bring scientific methods to inform the development, the evaluation, and the implementation of digital health tools that are really going to have impact? And that's been heavily focused on digital therapeutics for substance use disorders and related issues like co-occurring mental health or other chronic health conditions, but bringing science to that whole pipeline of developing, evaluating, and implementing to make sure we have not just the state of the science in terms of the most potent tools, but also the most engaging tools, right? If you have the most effective tools, but nobody uses them, the impact is nothing. So you really want to have something that, is both, effective and engaging and implementable so that it really has value, because we're not just about science, we're about scaling science so that we can actually bring the science to people's daily lives. So this is our website. I have a website address on the last slide, but there are lots of resources on our website, but we have a whole network. We're housed at Dartmouth and we have partners all over the Dartmouth community. Even though we're in the medical school, we have partners all over in computer science and the engineering school and the policy group and the clinician community. But we have partners all over the nation and internationally that work with us in many initiatives and that can also engage with our broader array of resources that we offer. So if you or your trainees, have interest research-wise or want some better understanding of clinically what can be done, we would be delighted to engage and provide any help we could. Some of the things we're up to now, please check out our website. There's lots and lots of detail about lots of projects, great work that folks are doing. Here are just some things that we've been prioritizing. We have been doing, we have a lot of, in the digital therapeutics world, we have a lot of siloed tools, right? So this one treats alcohol use disorder, that one treats insomnia. We know that a lot of health conditions co-occur and interact in clinically meaningful ways. Mental health and substance use is just one of many examples of that. And so instead of just doing one thing, we can embrace the complexity and interrelatedness of co-occurring conditions in the way we deliver digital therapeutics, and we don't have to put these artificial constraints on these tools to be so siloed. So we've been doing a lot in that space for a while, and lots of exciting new work in that space if folks are interested. Doing a lot of work in these adaptive digital therapeutics. Sometimes people call them just-in-time adaptive interventions. There's different names for them, where you, as we've talked about today, examples of how you can provide these personalized momentary interventions to an individual. We've been doing a lot of growing work in digital health ethics. This is something I think we don't talk enough about in this space, and we really want to have a parallel dialogue and even set of research activities in this space that parallels the broader field, rapidly evolving field of digital health. We've launched a couple of partnerships, national partnerships with programs that engage underrepresented minorities who are interested in substance use research to become digital health scholars in our group, to have the intersection of substance use and digital health training. And then we've been doing lots of things to enhance our collaborative work with lots of stakeholders, right? So we as scientists don't want to just be working in isolation. We want to engage in a national and global dialogue with the clinical community, the industry community, the regulatory space, the governmental space, the payer space, to understand, what people prioritize. How can we communicate the state of the science, but how can we also learn in the research community of what other things could be on our radar to study? When payers make decisions about what they're going to pay for, when FDA makes decisions what they're going to authorize, what are the important research questions we should be sure to embed in our science to help accelerate pathways to deployment? And so we've been doing a lot in this space. We hosted a very large digital health summit at Dartmouth around this in November, and have launched a digital health accelerator and lots of other exciting things happening that I'm happy to talk about if folks are interested. But I just want to underscore, I feel like it's a very interesting and unique moment in time in this space. And you worry that there's a lot of hype that sort of, and tools that may not be effective that could get out there. And so we feel really compelled to bring the scientific voice to this and hopefully partner in ways that really can have impact. So I want to stop there so we have lots of time for discussion. I did put our website address for our Center for Technology and Behavioral Health if you want to check it out. We also have a very lively social media life, so feel free to follow us on Twitter or Facebook. We would be delighted for you to join. So I'll stop there. I'll stop sharing so that I can also see the chat, and then hopefully we can have a conversation. I'd love to hear your thoughts and questions and comments. Thank you.
Thank you, Dr. Marsch. We would like to invite everybody who still has questions to enter those into the chat while Dr. Marsch is answering the questions that we have. Dr. Marsch, our first question is, can you address the missing elements of nonverbal cues and other visual missing observed elements as well?
Yeah, for some reason, your audio to me is very low. I can't hear it very well. Could you try that again, maybe a little louder?
Can you hear me now?
I can, yeah. It's a little soft, but I'll do my best to get to listen. Go, please try again.
Okay. Can you address the missing elements of nonverbal cues and other visual missing observational elements as well?
Okay, I think the question was around missing nonverbal cues and other visuals missing, perhaps, I guess, in the digital therapeutics. And if that's not the intent of the question, please, if the person who asked the question could either speak or add more content in the chat. So nonverbal cues and other visual missing observational elements. I'm not sure I fully understand the question. So I guess I don't fully understand the question. Maybe it relates to the digital assessment topic that I was speaking about. So I don't know, can we unmute folks or perhaps ask for some clarification on the question in the chat? Maybe we could come back to this one once we've gotten some clarification.
Hi, this is Meg. Who asked that question? Is it? I see one hand raised. Is that who asked the question? No.
It was Orlando Rivera.
Orlando, okay. Do you want to clarify your question? If so, can you raise your hand in Zoom? I can't, I don't see you. Oh, there you are. Hold on. Okay, see if you can talk now, Orlando. You're muted, but there you go. Okay.
So basically, I was asking the question with regards to the missing nonverbal cues that one generally would get when one has some sort of an assessment with an individual. Oftentimes, there are some elements that are missing that, like, for example, incongruency. If somebody, something along those lines, those would be some of the missing elements that I'm referring to.
Okay, so thank you so much for trying to clarify here. I'm sorry, I didn't fully understand. So are you suggesting, when you have a clinician-patient interaction, that the kinds of, like the example you just gave, that would be present there is not present when these therapeutic approaches are delivered via software?
Correct.
Yeah, got it. Thank you. Okay. Well, it's a great question. I don't know that anyone's fully embraced that question in any really intensely rigorous way from a research paradigm. I do think that, this is not seeking to replace clinicians and the value of that relationship. This can be additive. And in fact, absolutely, and I'm not sure I actually said this, it is the case that although you can have all kinds of flexible models of deploying these tools, the best effects and the best engagement happen when it is a tool that's offered in a model of care where the person also has a clinician, right? So this is some additional resources added on top of what's happening in the more traditional care model. And this is just a clinician extender is a tool that's used sometimes where it's an extension of what they're doing with a clinician. So that definitely drives the most engagement and value, and not trying to replace the clinician or try to replicate that, but just to provide reinforcements of what they're learning with the clinician that can be available, 24/7. It is, though, the case, and this is a little bit of a tangent to your question, but your question makes me think of this. It is the case that it's interesting that even as patients develop a therapeutic alliance with clinicians, we have seen in this digital health field that lots and lots of patient populations develop a therapeutic alliance with their digital intervention. It's very interesting, and so there is also that sort of value that people can derive in connection to that. In fact, I know some colleagues that have found that in a clinical trial, if they can't make a digital tool available in an ongoing way after the studies ended, that a lot of their patients are really distressed about that and really want to continue to have access to this thing that they've, sort of benefited from, that they'd like to continue to have access to. So I think it's a great question. And I if folks are interested in that, I think it would be a really interesting thing to directly take on as a research question. But I do also think that I think it's important not to think of this tool as trying to do exactly what clinicians do, because clinicians can do all kinds of things that this can't do, and these tools maybe can do some things that's harder for one clinician to do. So the combination, I think, is where we've seen the most value.
Perfect. Thank you, Dr. Marsch. Can you hear me better?
I can. Yes. Thank you.
Okay, perfect. The second question is, how about the ethics of this approach and the possible electronic breaches that would leave the HIPAA info exposed to the hacker?
Yeah, so there are all kinds of questions about ethics and, what data are collected, what data are shared, how they are shared, what are the best practices in this space. It's still evolving. I would say that there's a lot of attention paid to this, and including there's a group out of Cambridge Health Alliance and Harvard System, I think led by John Toros, that's doing some really great work to basically share for the digital therapeutics and the mental health space, what are all the privacy and data sharing practices of different companies for different apps? And there's a lot of variability there, and some have really terrific practices and use the data just in some have different practices of how they share the data. And I think that there's a lot of movement for more industry standards. There's a group called the Digital Therapeutics Alliance, which is a global trade organization. One of their biggest priorities is to have more standards in best practices and expectations of companies of what they do with data and how they share or don't share. There are some that have great models for this, and there's a lot of variability. And what's challenging a lot of times is what is patient-informed consent, right? How do patients really understand that? So this tool that John Toros and his team has developed is really great in that regard. FDA's got a Digital Health Center of Excellence now that's working on this too, Digital Therapeutics Alliance. I would definitely encourage the person who asked the question to go to the website of the Digital Therapeutics Alliance. Great information there about this. But there's still a lot of variability, and that's a big priority to tackle. That said, what's interesting is that there's also a very active dialogue around it, instead of just assuming that patients don't want data to flow. Some patients want data to flow in very specific ways. They want certain data to be shared with a clinician if the clinician wants to see that. They want data to be shared with maybe a support network or significant other. And so I think what other conversation is happening is, how do you align data to flow in a way that's aligned with patient preference, and not just all about sort of shutting everything down, but having flexible, controllable models of that. With HIPAA related data, I think so, some of these feed into EHRs, for example. Some don't collect. There's a lot of variability. Some don't collect, sort of things that would be sort of HIPAA related, and some do. And so it's kind of an evolving landscape, and it hasn't settled yet, but lots of people are paying attention to this, and maybe others on the call are working in this space too, and may want to chime in with comments about that in the chat. But I feel free to reach out if you'd like additional resources, but the ones I mentioned there, I think would be a great place to start.
Okay, the next question is, how do you get around existing barriers to access, even beyond payment barriers, employment, Medicare, Medicaid coverage that you mentioned?
Okay, well, so with the coverage issue, that's been the biggest barrier that people have talked about for years now. And I think there's been some excitement that there's finally been some movement in that space. As I understand it, there was literally one reimbursement code for digital therapeutics. And there's a movement to have an extended offering of different reimbursement codes linked to the different value of different digital therapeutics. So it's kind of like you wouldn't say there's one reimbursement code for medication, right? There's all kinds of different medications. They have all kinds of different indications and value, and there's all kinds of different levels of codes to match that. So there's a big movement for that. I think there may be 11, maybe 12 states now that have Medicaid coverage of some of these tools, but it's been really slow going because it has to be decided at the state by state level, and it's just been agonizingly slow. And I think that's what's been really frustrating for, we know from we work a lot with patient communities, and we know that there's growing demand in patient communities for these types of tools. Particularly, again, we work heavily in the space of substance use, and we know people want these, but they can't, it's another sort of consideration of equity of how do you get that to people if they can't get it covered through their Medicaid, for example. So it is a big issue, this issue of payment. And that is the biggest issue. I think other barriers have been in the early days of the FDA prescribed software model. I think that there was a lot of figuring out, how do you do that? I mean, literally people were writing a prescription that had to go through pharmacy, like a medication would, to get filled. And so that's been evolving a lot too, but that, really how to streamline that to make it a more efficient, low barrier way of access. I would say those are but the payment one always rises to the top as the biggest one. Because I think for me, for example, we've been doing this for a long time. And when we started that first version of this, what was a web version of the behavioral treatment for substance use in the late 90s, when we would go to, addiction treatment settings to partner on some studies, we got a lot of perceived threat among the clinicians. Like, what is this? I've never heard of this. Are you trying to replace my job with a digital intervention? And that conversation has changed completely since then, where what I see all across the world, but definitely in this country, is excitement, where people, are excited to have a novel offering within their care setting of something that their patients could be excited about, their patients could benefit from, and a resource that can be offered to them, the patients, when the clinician is not with them, and can reinforce what the clinician is doing with them. And so it's a lot of demand from patients and clinicians that's going unmet because they can't get it because of payment. I think those are the biggest issues. I know there's a lot of folks on the call that probably work in that sector, and I would love to hear what your experience might be around that. But I do think that in my experience, that's probably one of the biggest issues and conversations that I hear right now.
Thank you, Dr. Marsch. The next question is, to what extent is clinical digital tools used in the criminal justice system?
Yeah, I love that question. It's not used routinely in the criminal justice system. And, I know that, and nor has it really been extensively studied. We did a study years ago in a prison, multi-state study in different prisons where we looked at the digital treatment for substance use disorder among that population. But, in terms of tools that you could, there's such great promise about thinking about giving someone a tool before they're reintegrating into community and having continuity and access to that tool and therapeutic support once they are released from a period of incarceration and reintegrate into the community, that can give them some seamless continuity between, that one system until hopefully they can get, ongoing care and community. And I think there's extraordinary opportunity there, and including in help with the very high rates of overdose that we see when people leave a period of incarceration. There's strikingly high rates relative to other populations. And so I do think there's a lot of interest in that. I do think that funders have been interested in that. Some folks in our group are doing some early formative work in that. We have a study now, which is not a study of a digital treatment, but it's a study of looking at different long-acting medications among people who are in carceral settings, who then, when they leave that period of incarceration and reintegrate into community, we link them immediately to a community provider that can continue without disruption those long-acting medications, and we track their outcomes for a year post-release. And in that study, we actually give everybody a phone. We give everybody a phone mostly because that's our way of being able to stay in touch with them for a year. And so we can do our assessments remotely and stay engaged with how they're doing over the course of that year. And, because people jump for different locations and maybe are unstably housed and moving. And so this is a way we can better retain people in the study. And I can't tell you how many times we've heard and we've seen that this phone could do so much more than enable what I just described, and that's an opportunity to provide a resource that could go beyond, sort of support around substance use, but there are all kinds of other, as we know, needs of that population that we could think creatively about. How do you embed a whole support network, an array of resources or linkage to resources through tools offered on a mobile platform? So, I think there's extraordinary opportunity and need there. And if folks are interested in that, we would be delighted to talk to you about that, because I think if people have energy for and excitement for that, the need is huge, and the impact, I think, it could be extraordinary.
Okay, so question is, when using digital biometrics, how can you decipher if someone is exercising or, flip side, meditating versus other metrics that would show potential of drug usage or anxiety responses?
Yeah, it's a good question. So, there's certain data points you can put together to make some inferences about, you can never with great precision, just from the passive data collection, know exactly what's contributing to accelerated heart rate, for example, or other activities. But people are looking at different combinations of features that might give some insight into that. We even had a colleague through a project we did through NIDA's Clinical Trials Network, look at the feasibility of assessing cocaine taking behavior through a wearable, through a smartwatch, right? So we're not just looking at, excitatory physical activity, but, the very specific heart rate data, very granular heart rate data pattern that seems to be pretty specific to consumption of a stimulant. So, and that study was looking at the feasibility of, can you detect that, and can you detect even dosage of cocaine taking events just through passive sensing data? I'm happy to share that paper, papers, I guess, if folks are interested in that. But I think that that's still all being worked out, but you can, it's often, correlational. You can't, unless you can also ask people, they're labeled, people ask for labeling, we can briefly label something in the moment to link to your sensing data. And some people are doing that with certain methodologies, but a lot of it is inference about, your sleep quality, your sleep duration, your light exposure, your movement, your interaction with other people. You can actually capture in a way that's privacy preserving when people speak, not what they say, but there are all kinds of characteristics of speech you can capture, and frequency, and proximity to other people. And there's a lot of issues that you can understand and combinations that might help you understand some of these events. And then you can link it to outcomes, so you can link, when you see a certain pattern in an activity level, what patterns might predict when someone has a panic attack or some other event. And so a lot of people are doing those types of studies as well. If the person who asked that question is interested, one of our faculty at our center is just lives and breathes this stuff and is an incredible expert in this topic, and I'd be happy to connect you to him if there's interest in some more real detailed follow-up.
Okay, I think we have time for one last question. The question is, AI, such as Chat GPT, is getting a lot of recent media coverage. What role does AI have in digital therapeutics?
Yeah, it's a great question. People are working on that. So people have tried to work on chatbots, some of which, in the early days, particularly had pretty canned responses when, to sort of to messages that a patient might input. And there's been some utility in some applications of that, but people are trying to create, including a group at our center, a chat functionality that feels like a clinician on the other end. And they've worked so hard. They could tell you they've had all kinds of, changes over the years to try to figure this out. I think it's really going to be hard, but I think there's some promise there. I think it's going to be hard because of the stochastic nature of it. Like it can do things that surprise you, they can't always predict. And so I think there's probably some opportunity for some combination of, I don't know, the field is evolving rapidly as we know, and as what the reference with Chat GPT. But I think we have to also be careful about, if we're making clinical recommendations, that, there's some sort of perhaps interim step where we have AI balanced within some framework of or some sort of not fully canned responses and not fully AI is an opportunity that I think is underexplored. But I don't mean to sort of be pessimistic about where this could go. And I definitely have colleagues here that would be delighted to talk to you about that, because it's something they're working intensely on with their team. So happy to connect you if that's useful. Feel free to reach out.
Okay, Dr. Marsch, we have time for one more question real quick. How much of a barrier is access to a digital device?
The device itself. That's a good question. It's interesting because if you look at the statistics and even like what we've done in different pockets of the world, including like rural Colombia, that one study I mentioned, a lot of times people have devices. They might not always have continuity in device access, right? They might lose their data plans and the device sort of goes away. So they might have different devices. What can happen as a big barrier is connectivity problems, right? So if you have a tool that relies on internet connectivity in order to work, it's a real disadvantage. So, you really want to think about from the development side, having something that can have value and clinical utility, even when you're not connected, right? Something that can reside locally on a phone. And maybe when you do have connectivity, it can push upgrades and capture data or whatever, is needed for that tool. But I do think connectivity has been one of the bigger issues more than device access. There are actually more mobile phone subscriptions in the world than there are people in the world. It's really striking. And again, even in some of the communities you think would be really very disadvantaged and may not have access, we don't see that as much. So there's a lot of excitement about how can you think about, equitable models of healthcare delivery that leverage this technology access to try to think about sort of resource delivery in an equitable way. So thank you for that. That's a great question.
Okay, we don't have time for any more questions. Thank you so much, Dr. Marsch, for this wonderful presentation. And thank you to those who joined us today. And we hope everybody has an excellent week.